The anatomy of the wall of the heart that has three main layers: an outer epicardium, which is a connective tissue and fat, a middle muscular myocardium, and an inner endocardium. The endocardium is a thin, smooth interior lining of the heart covering the heart valves. It is composed of specialized endothelium similar to that of blood vessels and in connective tissue. Now, if we classify the endocarditis can be classified as left-sided, which is either mitral or aortic valve, or right-sided, that is tricuspid or pulmonary valve. It, it, it all is depending on any valve affected. Most cases involved are left-sided, only 5 to 10% are right-sided. This may further be subdivided into native valve endocarditis, where the patient's own heart valves are affected, or prosthetic valve endocarditis. Now, these prosthetic heart valves are designed to replace the function of native valves by maintaining the unidirectional blood flow and can be separated into two broad categories: mechanical and bioprosthetic, which is also called tissue valves. Each with different advantages and disadvantages are there for each of them. Bioprosthetic valves are usually made from animal tissue, and these are heterografts or xenografts, which are attached to a metal and polymer support. With bovine cow tissue is mostly used, but some are made from pig tissue. The tissue is treated to prevent the rejection and calcification. Prosthetic valve endocarditis makes up 20% of all endocarditis cases. 6% of these most severe form of endocarditis, and prognosis is often poor. Early prosthetic valve endocarditis is seen within 12 months of surgery and is due to intraoperative contamination or spread of valves via the blood within the days and weeks of operation. Staphylococcus aureus is the most common associated with early prosthetic valve endocarditis. Now, the late prosthetic valve endocarditis, on the other hand, is a community-acquired infection that occurs more than 12 months post-op and is caused by similar microorganisms that are found in native valve endocarditis, which are Streptococcus and Staphylococcus aureus. The biggest drawback of mechanical heart valve replacement is the need for lifelong blood thinning medications or anticoagulation. Now the blood thinning treatment comes with the risk of bleeding complications. The most appealing part of a bioprosthetic heart valve that does typically require a blood thinning medication. Structural valve deterioration is clinically important long-term complication of bioprosthetic valves, causing stenosis, regurgitation, or combination of both, ultimately necessitating reinvention. Valve thrombosis, thromboembolic complications, and pannus formation occur more frequently with mechanical valves. Growth of abnormal tissue around the prosthetic valve is actually termed as pannus formation and is one of the most important causes of prosthetic valve dysfunction that may require repeated open heart surgery. So, how we differentiate pannus formation from the other regions is that pannus is more chronic process associated with ingrowth of tissue causing obstruction. Distinguishing between the thrombus and the pannus as a cause of obstruction is important because thrombus can potentially be treated with fibrinolysis, whereas pannus requires surgical intervention to relieve the obstruction. Infective endocarditis is an infection of endocardium, cardiac valves, and more rarely extracardiac vascular endothelium, more correctly termed as infective endarteritis. The disease can be fulminant or rapid onset, where it is termed acute endocarditis, but more commonly it runs a chronic insidious course and is referred to as subacute endocarditis. Infective endocarditis in elderly is mostly on the background of either degenerative valvular disease or prosthetic valves. Congenital heart disease is an underlying lesion in 10 to 20% of the cases of infective endocarditis. Common lesions such as ventricular septal defect, patent ductus arteriosus, bicuspid aortic valve, while the uncommon lesions such as coarctation of aorta and teratology of Fallot and pulmonary stenosis are the affecting lesions. Other conditions associated with infective endocarditis include mitral valve prolapse, hypertrophic cardiomyopathy, especially if associated with outflow tract gradient, and aortic regurgitation, which is secondary to Marfan syndrome or syphilis. Mitral valve prolapse is now becoming an increasing important and underlying cause of infective endocarditis. Now here we have to differentiate between two particular lesions that are associated with infective endocarditis. One is Osler's node and the other is the Janeway lesions. But Janeway lesions are painless. Typically, Osler nodes typically affect finger, toes and nodules, while Janeway lesions typically affect palm, soles, macules and papules. The Osler nodes are purple-pink with pale center and are erythematous, hemorrhagic, localized immune-mediated response to subacute endocarditis and last hours to days, while Janeway lesions are septic emboli, which are acute endocarditis. They last days to weeks. There are three hemodynamic determinants for endocardial denudement. The first one is a high velocity abnormal jet stream, while flow from a high or low pressure chamber is also a reason. Finally, a comparatively narrow orifice separating the two chambers, resulting in pressure gradient. This explains high rate of infective endocarditis in valvular lesions such as aortic stenosis, mitral regurgitation associated with high velocity jets. Similar non-valvular lesions with high degree of turbulence such as small ventricular septal defect with a jet lesion or atriovenous fistula, patent ductus arteriosus and coarctation of aorta readily have a high incidence of infective endocarditis, whereas large defects with low flow, for example, secundum atrial septal defect, which is actually a large hole in atrial septum, such situations have low incidence. The lesion of infective endocarditis tend to occur on low pressure side of the jet lesion. For example, the atrial surface of incompetent mitral valve with possible stellate lesions, which is similar to the lesion near the edge of the principal lesion. It is where the jet stream strikes the endocardium. Now, for infective endocarditis to develop, a complex interaction is required between vascular endothelium and endocardium, and a hemostasis response in circulating bacteria with normal endothelium is a non-thrombotic and resistant to attachment of bacteria. When endocardial surface is denuded of cells and the underlying collagen is exposed and is a potent stimulus for hemostasis. As a result, a clot of platelets and fibrin develops, creating a sterile vegetation. This stage of process is referred to as non-bacterial thrombotic endocarditis or NBTE. This produces a more receptive surface of bacterial adherence and colonization. The adherence of bacteria is mediated extracellular molecules such as fibrinolectin and dextrans, which lead to formation of an infected vegetation, and the pathological hallmark of infective endocarditis. Subsequent deposition of platelet and fibrin form a protected site for the bacteria in which the phagocytic cell can't freely enter. This allows survival and proliferation of infecting organisms. There are three hemodynamic determinants of endocardial denudement: a high velocity abnormal jet stream flow from high to low pressure chamber, a comparatively narrow orifice separating the two chambers, resulting in a pressure gradient. This explains the high rate of infective endocarditis in valvular lesions, such as aortic stenosis and mitral regurgitation, associated with high velocity jets. Similar non-valvular lesions with a high degree of turbulence, such as small ventricular septal defect with a jet lesion, or atriovenous fistula, or patent ductus arteriosus, or coarctation of aorta, readily have a high incidence of infective endocarditis, whereas large defects with low flow, for example, secundum and atrial septal defect, have a low incidence because the opening is large. The lesion of infective endocarditis tend to occur in low pressure side of the jet lesion. Example is atrial surface of incompetent mitral valve with possible satellite lesions where the jet stream strikes the endocardium. Now, microbiology wise, the causative organism is usually bacterium, but other organisms may be involved, and therefore infective endocarditis is better termed to use rather than traditional terminology bacterial endocarditis. The common organisms involved in intravenous drug abusers are streptococci, which make up 45 to 50% of the cases, while staphylococci make 25% of the cases, and enterococci make 10% of the cases. Now, streptococci are the most viridious type, beta hemolytic type, commensals of oropharynx, cause infective endocarditis following dental procedures, bronchoscopy. Indolent course mostly affects abnormal valves. The big problem in IV drug abusers is Staphylococcus aureus causes acute fulminant endocarditis. Intravascular catheters pose a potent risk. Septic staphylococcal epidermitis is common in patients with indwelling catheters associated with a high rate of metastatic embolization and can be multi-drug resistant, also called as MRSA. Enterococci, on the other hand, inhabit gastrointestinal tract and genitourinary tract. Following the GI and GU instrumentation, growing incidence of antibiotic resistance, for example, vancomycin-resistant enterococci or vancomycin-resistant enterococci within the system are getting resistant. Now, on clinical examination, all patients with suspected infective endocarditis require a thorough cardiovascular examination. Typical clinical findings in the infective endocarditis include fever, tachycardia, new or changing heart murmur, splinter hemorrhages, nail-bed petechial hemorrhages. Splinter hemorrhages occur when small blood vessels called capillaries under the skin beneath your nail and nail bed burst due to damage, while ocular nodes, which are tender subcutaneous nodes in the fingers, ocular nodes are like split pea-sized erythematous tender nodules located principally on pads of fingers and toes, while Janeway lesions are irregular non-tender hemorrhagic macules located principally on the pads of the finger and toes, while Janeway lesions are irregular non-tender hemorrhagic macules located on the palms and soles and thinner and hypothinner remnants of the hands and plantar surface of toes. They typically last for days or weeks, while rot spots are defined as white central retinal hemorrhage. Rot spots appear on your retina as areas of blood with pale or white centers. The white spot is made of fibrin, a protein that works to stop bleeding. These spots can come and go, and sometimes appearing and disappearing in a matter of hours. Clubbing typically is a late sign Digital clubbing has classically seen on the palm shows thinner and hypothinner evidence of the hand and the plantar surface of the toes. They typically last for days or 2 weeks. The rot spots are defined as a white-centered retinal hemorrhage. Rot spots appear on your retina as area of blood with pale and white centers. The white spot is made of fibrin, a protein that works to stop bleeding. These spots can come and go, and sometimes appearing and disappearing in a matter of hours. Now, clubbing is also a situation where typically a late sign of digital clubbing has classically been associated with chronic infection such as bronchiectasis and lung abscess, empyema, pulmonary tuberculosis, infective endocarditis, both inflammatory bowel disease such as Crohn's disease and more than ulcerative colitis, and chronic liver disease have been associated with clubbing. Mild splenomegaly occurs in 37% of patients with active and infective endocarditis, and in 64% of those with prosthetic valve endocarditis. It is most often due to congestion, hyperplasia, and infarction. Bibasilar lung crepitations are due to heart failure. In severe cases, bibasilar cracks are a bubbling or crackling sound of originating from the base of the lung. They may occur when the lung inflate and deflate. They usually are brief and may be described as sounding as wet or dry. Excess fluid in the airway causes these sounds or crepitus in the lungs, and is caused when collapsed or fluid-filled air sacs abruptly open when you breathe. Also referred to as crackles or rales, the sounds are related to abnormalities in the lungs. Most often the sounds signal that there may be lung scarring or buildup of excess fluid. Patients may also be present with clinical features from emboli, for example, weakness from a stroke. Infective endocarditis is an established common cause of septic emboli from a case study as early as 1883. Here, the parts of vegetation or valve infected dislodge and travel through the bloodstream and block blood vessels based on size and location. Now, if we see the symptoms of endocarditis, the symptoms are actually acute. Infective endocarditis usually begin with fever of 102 degrees to 104 degrees, chills, fast heart rate, fatigue, night sweats, aching joints and muscles, persistent cough, and swelling in the feet and legs and abdomen. Now here we have to differentiate between two particular lesions that are associated with infective endocarditis. One is Osler's nose and the other is the Janeway lesions. But Janeway lesions are painless. Typically, Osler nodes typically affect finger, toes and nodules, while Janeway lesions typically affect palm, soles, macules and papules. The Osler nodes are purple-pink with pale center and are erythematous, hemorrhagic, localized immune-mediated response to subacute endocarditis and last hours to days, while Janeway lesions are septic emboli, which are acute endocarditis. They last days to weeks. Now, diagnosis of infective endocarditis is not directly given as a direct definitive diagnosis, but requires particular major and minor criteria as shown in Duke's criteria. Now, the major criteria in the Duke's criteria is that blood culture is positive for typical microorganism, example Staphylococcus aureus or Enterococcus viridans or Streptococci, or echocardiogram showing valvular vegetation, whereas the minor criteria is the predisposing cardiac lesion, intravenous drug use, temperature greater than 38 degrees Celsius or 100.4 Fahrenheit, Embolic phenomena, immunologic phenomena is, for example, glomerulonephritis, positive blood culture not meeting above criteria. Now, the definitive infective endocarditis requires two major or one major plus three minor criteria, or possibly this endocarditis depends on one major plus one minor or three minor criteria. And that is all for the diagnosis of endocarditis. The other lecture will basically be on how to manage the infective endocarditis cases. Thank you. Thanks a lot. Do like, share, and subscribe if you like it. Thank you.